Hello all, I am Jaya Sreevalsan-Nair presenting the work done with my colleagues Rani Reddy and Pritesh Gokil on the influence of COVID-19 transmission stages and the demographics of a country on the length of in-hospital stay LOS as observed in Singapore during January 23rd to April 1st when it crossed its first 1,000 patients. Since December 2019, COVID-19 outbreak has infected around 90 million people from 216 countries by late June 2020. 0.5 million have died and 5 million have recovered. A country's socio-economic priorities influence its pandemic response, also reflected in its recovery statistics. Here we ask, do the variables such as COVID-19 transmission stage in a country and the age-gender structure of its population influence the recovery period, that is the LOS for that country? Singapore has been prepared for COVID-19. The 2003 SARS outbreak had a fatality rate of 13.9% in Singapore. Towards its readiness for future pandemics, public healthcare system has been improved. It has the NCID and the biosafety level 3 labs, definite protocols for hospital surveillance, contact tracing and admission, digital platforms for intergovernmental agency cooperation. The Ministry of Health MOH has published case-wise data online through daily press releases for COVID-19. The data includes unique case ID, age, gender, dates of symptom onset, and date of hospital admission. Hospital discharge or death are announced as and when along with the case IDs. MOH also published hospital protocol, admission upon a positive RT-PCR test and discharge only upon 2 consecutive PCR tests, both negative 24 hours apart. Note the completeness and the reliability of the open anonymized data that we have used. In comparison to a fellow ASEAN country with similar data dissemination, South Korea was slow in its early response to COVID-19. In its quick progression to community transmission, had it crossing its first 1,000 patients in just 38 days with 1,261 infected and 24 discharged, while Singapore took 70 days for 1,000 infected and 245 discharged. The consistent response to slow progression of the pandemic has improved recovery rate from 24.5% in April to 85.7% now in Singapore, despite a dip to 7.4% in May. We analyzed the recovery period against transmission stages and demographics-based vulnerability. There are 4 transmission stages of the pandemic in sequence in a country. Stage 1 is imported cases, Stage 2 local transmission, Stage 3 community transmission, Stage 4 epidemic. Periodizing the time frame in Singapore until April 1st, we have 3 periods based on stages. P1 January 23rd to February 3rd, P2 February 4th to March 16th and P3 March 17th to April 1st. There is an influence of age and gender on the morbidities of COVID-19, hence school children and senior citizens are considered vulnerable. We have 3 age bands here, 0 to 19 A1, 20 to 59 is A2 and 60 plus years is A3. The population pyramid in A1 shows that the age-gender distribution of 245 recovered is different from that of the 1,000 infected. A2 shows that the distribution of infected population has shifted from vulnerable to non-vulnerable population from P1 to P3. A3 shows that the age-gender distributions of the recovered populations are similar in P2 and P3. Diagram in B1 shows that the 18 infected in P1 has recovered in P2. Some of the patients in P2 have recovered in P2 and P3, giving rise to different grouping strategies. B2 shows that there is a sudden uptake of infections in P3 and B3 shows that there is a slow uptake in the number of recovered over time. The statistical analysis shows that both male and female genders have similar measures in plot 1. Plot 2 shows that there is no characteristic behavior in LOS for 0 to 19 years, monotonous increase in 20 to 59 years and monotonous decrease in 60 plus age groups. 3 shows a monotonous decrease in LOS from P1 to P3. 4 shows the time series of LOS for case IDs in the form of a scatter plot. The LOS, a local regression model, shows a definite downward trend in LOS. There are 2 strategies for period-wise grouping of patients, grouping based on the periods corresponding to the admission dates and to the discharge dates. We group based on the period of admission dates. This is owing to the similarity of the circumstances for those with closer hospital admission dates. This is shown in the cohesive period-wise trends in the scatter plot. To estimate the LOS using the multivariate regression model, we use 2 models of the generalized linear model with age, gender and period as independent variables and LOS as the dependent variable. Model M1 uses all the 245 observations and M2 uses 3 piecewise linear models split across 3 age bins A1, A2 and A3 with a split of 18, 161 and 66 patients. LOS is count data with overdispersion and a naturally skewed distribution that can be approximated using Poisson or negative binomial distributions. Negative binomial is a better fit owing to the lower error measures. Overall, the descriptive statistical analysis shows that the LOS has reduced from 16 to 9 to 8 days from P1 to P3. The piecewise regression shows an estimate of 9 days as a maximum likely value across both vulnerable and non-vulnerable populations. The periodization based on the transmission stage is found to be statistically significant for LOS estimation and so is age, but for P3 specifically. LOS is equivalent to the virus shedding period here owing to the hospital protocol. Thus, our 9 days estimate is lower than the virus shedding period published for data until April 1st, that is 15 or 20 days. For more details, please check out a paper on medRxiv. Thank you for your attention.